You're listening to Medscape's In Discussion series on lung cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Jacob Sands, Assistant Professor of Medicine at Harvard Medical School and physician at the Thoracic Oncology Program at the Dana-Farber Cancer Institute in Boston, Massachusetts. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for you as healthcare professionals.
Hello, I'm Dr. Jacob Sands, thoracic medical oncologist at the Dana-Farber Cancer Institute. Welcome to Medscape's In Discussion series on lung cancer. Today we'll be discussing immunotherapy in metastatic non-small cell lung cancer, and I am very excited to introduce my guest, Dr. Stephen Liu. Dr. Stephen Liu is an associate professor of medicine and the director of thoracic oncology and of developmental therapeutics at Georgetown University in Washington, D.C. Dr. Liu, welcome to In Discussion.
Thanks for having me, Jacob. Real pleasure to be here. A big fan of the podcast.
So I'd like to start out with a bit about your personal journey. What interested you particularly in focusing on lung cancer?
Well, Jacob, I wish I could tell you that I was interested in lung physiology from an early age. It's not true. To be honest, it was more of a pragmatic decision. During fellowship, I was at USC in Los Angeles. All of my fellowship research was in prostate cancer. That's where I had all my publications, my grants, my mentors, and that's really the career I envisioned for myself. But when I finished fellowship applying for jobs, it was important that I stay at USC. My wife was still in training there. And while they offered a prostate cancer job there, they had a lot of prostate cancer doctors. So from the jump, I would have been pretty redundant, which isn't the best career path, I think, early on. So the options that it shook down to were to take a prostate cancer job across town at a different university, or to stay at USC and do lung cancer, where there really was more of a need. And I chose based more on location. So it was much more of a pragmatic decision. I can't tell you why I decided to stay in lung cancer, because I've since moved institutions. And I think that what's left me in the field, what sort of kept me here, was really the people. This is a very lethal disease, as you know. And I think that when you meet patients that are diagnosed with lung cancer, they're often very sick. And it's a very special type of relationship because it's a bond that's formed under a lot of duress. And I think it's a very privileged type of relationship that I really enjoy. I know that I'm biased, but I think that the lung cancer community, the academics, the specialists, I think these are really among the best people out there. And part of it is that when I am at a conference or a meeting and I see another lung cancer doctor, I know that you have probably had a pretty rough clinic. And I think that the community is very supportive of each other. You don't see a lot of sort of competitive bickering. It's a very supportive community. I think it's because we know we need that support. And so I think that this community, maybe more so than other specialties, really comes together. And I think it's a great place to thrive and to grow.
That has definitely been my experience as well. And I can certainly say, I think on behalf of many within the academic lung community, that we are so grateful that you have chosen to stay in lung cancer treatment and that you ended up as one of our colleagues within lung oncology. You've certainly been a leader in it. And you're right. I think the history of lung cancer has been certainly a rough one. There are some really remarkable new advances, and we're going to discuss some of that, some of what we're really seeing and really some of the more exciting cases being with immunotherapy. Of course, we also have targeted therapies that we talk about in other environments. We're going to focus on the immunotherapy today. We're going to discuss various checkpoint inhibitors, but we'll start with the Keynote trials. We had Keynote 24 with pembrolizumab, Keynote 42, and then of course we had the combination chemo-pembro studies as well. But do you want to just take us through a bit of an overview of the pembrolizumab-related Keynote trials?
Sure. I mean, these are really hugely monumental studies that changed not just our standard of care, not just our treatment algorithms, but they really changed how we perceive the disease and what we're capable of in treating someone with metastatic lung cancer. Early on in my career, we saw the introduction of immunotherapy as salvage treatments for heavily pretreated lung cancer in the second-line setting, replacing docetaxel. The first-line study that really changed the field was Keynote 024, and Martin Reck presented this at ESMO 2016. to a standing room only audience. This was a randomized phase 3 study that randomized patients with treatment-naive non-small cell lung cancer, so no prior therapy. They were randomized to receive immunotherapy, which was pembrolizumab for a period of 2 years, or chemotherapy. Immunotherapy was clearly better. It was better tolerated. It worked better, worked for longer. It's our new standard of care. This was for PD-L1 high non-small cell lung cancer. But at the time, there was a little concern about this study, and some of our colleagues didn't really have equipoise because we had learned over many decades of studies that chemotherapy improves survival, and immunotherapy didn't work for everyone. And the thought here was, if we gave immunotherapy as a frontline treatment and it didn't work, the natural history of this disease wouldn't allow some of those patients to get second-line treatment. So there were some people that thought this is really kind of a risky study and weren't sure if it should go forward. We're glad that it did because, pembrolizumab was by far the better option, improving survival, even with crossover built in, even with immunotherapy available as second-line treatment. The survival doubled, median survival from 13 months to 26 months. And we now know that the 5-year survival rate is over 30% with pembrolizumab alone. So from October 2016, it became below the standard of care to give chemotherapy alone as a frontline treatment for PD-L1 high lung cancer. We then saw that indication expand. PD-L1 high lung cancer is about a third of metastatic non-small cell lung cancer. What do we do for the other 2/3? Well, for PD-L1 low, we saw KEYNOTE-042. Now, KEYNOTE-042 was including people with a PD-L1 score of 1% or greater, so about 2/3 of the population. And what we saw there was the study overall was positive, but in that PD-L1 low group, immunotherapy wasn't convincingly better than chemotherapy. Not necessarily worse, but not convincingly better. And so we wanted something more there, and that more came in the form of adding chemotherapy. Chemotherapy maybe does two things. One, there is certainly an additive benefit, and so you can benefit from the chemotherapy alone and from the immunotherapy alone. And there's some suggestion that there might be synergy between them, that giving chemotherapy might allow the release of neoantigens that might invoke an immune response. Clearly, though, the combination is an established option. KEYNOTE-189 was a combination of carboplatin or cisplatin with pemetrexed and pembrolizumab. And then KEYNOTE-407 was a taxane, either paclitaxel or nab-paclitaxel with pembrolizumab for squamous lung cancer. Both of those combination studies showed that when you add the checkpoint inhibitor, when you add pembrolizumab to that platinum doublet, you improve survival. And this was seen across PD-L1 strata. And now for someone that doesn't have a driver mutation, we know that immunotherapy has to be part of frontline care. You can't save it for later use. And it's either given by itself or given with chemotherapy, but it's got to be immunotherapy because better outcomes in the short term, more importantly though, better outcomes in the long term, and the potential for really durable, meaningful, transformative types of responses.
That's a great, concise overview of a whole bunch of information. And so just to further overlay on that, with KEYNOTE-024, this was being with a PD-L1 expression of greater than or equal to 50%, and then 042, including that greater than or equal to 1%. And then the combination trial of chemo-pembro included all comers. And I really highlight that because I sometimes see people forget that in the first-line setting, if the PD-L1 is less than 1%, these patients are still ones that I generally treat with chemo plus pembro. They're certainly eligible, and within the forest plots of those trials, that did appear meaningful as well. You've mentioned the improvement in median survival and in tolerability and such. You said a 5-year survival of 30%, and this is a really remarkable statistic in the setting of metastatic non-small cell lung cancer. Can you talk a little bit about the tail of the curve related to these KEYNOTE trials?
I think that's really what we look at now. Medians don't tell the whole story. It's not that immunotherapy benefits everyone. It doesn't, unfortunately. But if you do get immune-related responses, they can be extremely durable. And some of us use the word cure, and we have to sort of figure out how we best define that. 30% of people that received pembrolizumab alone are alive at 5 years. That's with PD-L1 high lung cancer. And, historically, that number would be in the single digits with other therapies. When we look at KEYNOTE-189, which, as you mentioned, was an all-comer study that included chemotherapy, platinum, pemetrexed, pembrolizumab, the 5-year survival there, about 20%. And so to think of 1 in 5 people alive 5 years later for what not too long ago was a uniformly and fairly rapidly fatal disease with a median survival of less than a year, we've come an extremely long way in a very short period of time. So for a subset of patients, we do achieve meaningful long-term survival that might approach what we would call a cure.
Let's move on now to Nivo-Ipi. We've seen a couple of different trials that have led to FDA approvals in the first-line setting. Can you take us through the CheckMate studies?
Boy, I don't think we have enough time to go through the design of CheckMate 227. It's one of our more complicated studies. But I think that at the crux of it, you're looking at dual immunotherapy, dual checkpoint blockade. PD-1 and PD-L1 are important checkpoints that in a cancer will prevent immune activation, immune recognition of cancer cells. And by blocking those checkpoints, we can restore this anti-cancer immunity that we sort of see normally. With CheckMate 227, CheckMate 9LA, we're now incorporating dual checkpoint blockade. So in addition to blocking PD-1, we're blocking CTLA-4. CTLA-4 inhibitors such as ipilimumab in the CheckMate studies or tremelimumab in the more recent Poseidon study are used more in priming the T cells, and those have an established role in melanoma, in kidney cancer, in lung cancer. While they are associated with a different toxicity profile, they also are associated with extremely long, durable responses. CheckMate 227 was a combination of nivolumab and ipilimumab, and this showed a benefit. It is approved only for PD-L1 positive, but it did show benefit in PD-L1 negative as well. This was across histology. CheckMate 9LA is that same combination of nivolumab and ipilimumab, but in combination with chemotherapy given for only 2 cycles, and that's to maybe prevent that early progression that we can see for those that aren't so immune responsive, and that combination also FDA approved. So it really is this embarrassment of riches where we have multiple agents, most recently the Poseidon regimen of durvalumab plus 5 doses of tremelimumab plus 4 cycles of chemotherapy. So a lot of subtle differences here, but what we have is a lot of options. Now, if the question is, does adding CTLA-4 sort of improve outcomes compared to PD-L1 alone, we don't have sort of the right direct head-to-head comparison yet. And so we're left with just a lot of different options.
And the balance in this that I hear debated is a CTLA-4 raising that tail of the curve where you're getting potentially more durable benefits. Of course, now we're doing cross-trial comparison and even having this discussion, which, as we know, statistically you cannot do. But at the same time, when we're meeting with patients, that's exactly what we have to do in deciding what's the right regimen for that individual. So on the potential upside, looking to raise that tail of durable responses while accepting a bit more of a toxicity profile. What does that equation look like for you? How do you weigh those out?
What we really need is a good biomarker for who's going to get that extra benefit from CTLA-4, who needs it. Because if you have someone that's in that 30% from Keynote-24, that's in that 20% from Keynote-189, we don't need to add a CTLA-4. If I knew up front that this person was destined for 5-year survival, then it's not really worth adding that extra drug, the extra cost, the extra toxicity, the extra risk. But, how many people are we converting from sort of a non-survivor to a survivor by adding that? And we don't know the answer to that. We can't tell who those people are up front. For me, CTLA-4 is an attractive option, even without a biomarker, but I really only consider it in the right patient. When we think of what CTLA-4 adds for sure, it does add another layer of toxicity. And these are immune-related toxicities that, as we know, can escalate in a hurry, can get out of hand very quickly. And so if I have a patient who is seeing me for frontline therapy, everything's on the table, and this person lives very far away. This person lives completely on their own. Maybe, I have some that live quite rurally where they don't have phone coverage. Also people that maybe aren't complainers, sort of keep things to themselves. What I don't want is I don't want someone that's going to have an immune-related colitis and I don't find out about it for a week or two. That I think is sort of the wrong type of population to think of CTLA-4, just because I think the risk is a little bit higher there. And I want someone that's got a little more support, a little more engaged, a little more access to help, to be sure that if there is a toxicity, we recognize and treat it very quickly. That's my biggest concern.
Yeah, I want to highlight that first statement you made of essentially trying to identify those in which we can convert what would not have been that really durable response with a PD-1, PD-L1 inhibitor alone into one of those durable responses. And what you're describing is trying to find that population that really the CTLA-4 is going to be the thing that really matters in that individual having a long, ongoing response to therapy. And sometimes I hear people say, well, we need now the next research is to figure out how to make the checkpoint inhibitors or immunotherapy work better. And I say, well, the nuance to that is not necessarily make it work better for those that it's working for, because we have some people that are really having remarkable ongoing benefits, but how to make it work that well for more people. And that's what you're highlighting, and also recognizing that we don't currently have a good biomarker for that. But it sounds like that's what you're really pinpointing as an area of huge need in identifying who would have that benefit by the inclusion of a CTLA-4 inhibitor, which gets to then the statement or kind of the logical conclusion that you believe there is a population there that is benefiting from the inclusion of the CTLA-4 inhibitor. And in your cross-trial comparison, you're assessing that there is likely a larger number of patients that are benefiting from the inclusion of CTLA-4 inhibition.
I think there is. And, a lot of these differences are difficult for us to measure. The numbers are quite small. To me, the leading candidate today might be STK11 mutations. We know that this predicts for a relatively immune refractory population, and some convincing evidence from MD Anderson and Hopkins, led by Nanda Skalidis, show that when you have these specific mutational profiles like STK11, that those patients didn't really seem to get a lot of benefit from the addition of immunotherapy. Now, it was all retrospective data, but very convincing retrospective data. The bar, though, is a little higher to withhold immunotherapy. And rather than not give those patients immunotherapy, I think a better sort of strategy is to find different immunotherapy strategies. In the Poseidon data set, we did see that patients with an STK11 mutation did seem to get more relative benefit from CTLA-4 PD-L1 from the addition of tremelimumab to durva than durva alone. Now, that was shown with these tails of the curves that at landmarks like 2 years and 3 years were quite a bit higher in those populations. But as you know, Jacob, those numbers are very small. We're talking about data sets of like 12 to 18 patients, which is relatively small to sort of base a whole strategy on, but it's a start. And I think we just need to sort of pool our forces and really identify what those biomarkers are.
Yeah, and then not to leave out, of course, we have atezolizumab, the Empower studies, which are Empower regimens, I should say, where we have kind of a combination. This was one of the earlier publications as well, but of course had the inclusion of bevacizumab in that initial statistical analysis. What is your assessment of that? Is this part of your equation? Can you give us an overview?
Yeah, so there are a lot of agents out there, and if we're just talking about only the U.S.-based regimens, it's a long list. When we start getting into other regimens, for example, in Asia, the list grows even longer. But atezolizumab is approved in the frontline setting, and that was the Empower 110 study led by Dr. Roy Herbst. What we saw was atezolizumab compared to chemotherapy. Atezolizumab did improve survival compared to chemotherapy in that PD-L1 high group, and so it is another option in that setting. I don't think that it's convincingly better or necessarily worse than pembrolizumab, but it is another option. There are different chemotherapy backbones associated as well. So we have atezolizumab with nab-paclitaxel and carboplatin. That was the Empower 130 study led by Jack West. And while that is an approved regimen, and the addition of immunotherapy to chemotherapy did improve survival, and I think it's the right answer on a board exam, it's hard to find a use for that specific regimen. Maybe if you had an adenocarcinoma where you couldn't give pemetrexed, there are maybe some niche populations, but I think that's one that probably hasn't found its home just yet. The Empower 150 regimen is a little different. That's carboplatin, paclitaxel, bevacizumab as a backbone based on the ECOG 4599 with the addition of atezo. And the addition of atezolizumab did improve survival. It is an approved regimen. To me, I think that what sets that regimen apart really is its activity maybe in the EGFR mutant space. And so what we did see was potentially some benefit in patients with an EGFR mutant lung cancer after TKI, not as the initial treatment, whereas you didn't really see that benefit with atezo alone and without the bevacizumab. And it kind of fits in with other studies we've seen. We saw that sintilimab plus anti-angiogenesis did improve outcomes in EGFR mutant, whereas in more recent data, Keynote 789, pembro alone did not improve outcomes when added to chemotherapy in EGFR mutant lung cancer. So there might be something to VEGF inhibition with EGFR. I think it's still an unanswered question, but one that's important to ask. And when we talk to our colleagues in Asia, like in Japan, the Empower 150 regimen is hugely popular in Japan after TKI. There's a lot of EGFR there. They must know something. So I think it's something that needs a little further study.
So I debated starting this whole interview really with a discussion of next generation sequencing and looking at actionable alterations and such. And the reason I held off was actually because of this data that you're specifying. So maybe this is a good kind of segue now into genomic testing and how that fits into this whole picture. I personally will do next generation sequencing on all patients with a non-squamous non-small cell lung cancer. Anyone with a squamous without a smoking history or with a particularly limited and distant smoking history, I would also do next generation sequencing. I consider that to be standard of care. Of course, at an academic institution, we do have some patients with a significant smoking history and squamous that end up getting tested as part of some of our research studies that are observational. But generally speaking, I'd say standard of care is testing what I initially started with. Now, in most of the actionable alterations with an FDA-approved targeted therapy in the first line setting, I would treat in those cases. But you've highlighted really the Empower 150, although a first line trial, being second line after targeted therapy for EGFR sensitizing mutations, although the trials often don't specify what percent of patients with an EGFR mutation truly had sensitizing mutations as opposed to non-sensitizing or exon 20. How does genomic testing fit into all of this in your standard practice? And is Empower 150 a regimen that you would particularly consider in that setting, or it doesn't have to be? Do you think that there's more benefit to that one than others? Are immunotherapy something that you utilize after targeted therapies? I've given you a string of questions that I think all kind of fit together, but I'll let you go through that in whichever way you want to wander through it.
No, they do go together. And to answer your question, first, everyone that walks in my door with a diagnosis of lung cancer gets NGS. Whether it's early stage or late stage, regardless of histology, everyone's getting NGS. And I've been called many things, Jacob. I've never been called cost efficient. But to me, I need to know that information because it helps me not just choose what treatment we're going to do today, but what treatment we're going to do tomorrow. It tells me about the biology. It tells me what treatment to give and what treatment to avoid. And while I appreciate that NGS is not free, it is an expensive test, it's less expensive than one dose of immunotherapy. And if I see someone with an ALK fusion, with a ROS1 fusion that I wouldn't have otherwise detected, if it steers me away from a year or 2 years of immunotherapy, that it dwarfs the cost of an NGS test. And so I really consider it essential. And I understand that I speak from a position of privilege that we can do these tests, but everyone in my clinic is going to get that treatment. Now, when do we give immunotherapy to someone with a driver alteration? When we're thinking specifically of the non-smoking related mutations like EGFR, like ALK, it's pretty far down the line. For EGFR mutant lung cancer, it's TKI, and then I'm going to use biopsy to try to guide more rational combinations, trial delivery. I guess my point is, if I'm going to give immunotherapy, I'd like to give it with VEGF and potentially with chemotherapy. If we're going to do that, then I think that's probably the best currently available way to deliver immunotherapy. If we're talking about second line PD-1 or PD-L1 inhibitor alone, I don't have a lot of excitement about that delivery. So if we're going to do immunotherapy, I think using an Empower 150 regimen makes sense. I'm less excited about it, though, if I need to continue TKI. And that's specifically in patients with brain metastases where I think there's value in continuing the TKI to maintain CNS control. TKI plus immunotherapy doesn't mix well. And so those are settings where I'm probably not going to give immunotherapy, maybe ever.
So it sounds like the use of these regimens is a bit of an outlier for those with an EGFR. You have other preferences, of course, looking for other targeted options and such. But if you're using it, the Empower 150 regimen would be your choice. And so let's use that as a jumping point then in synthesizing all of these. We talked about a lot of different regimens. You've specified some specific subpopulations within there. Can you take us through kind of an overview of your treatment strategy? How you would, when you see someone in clinic and you're talking about first line setting, let's say no actionable alterations as far as, no targeted therapies, just that clearly is not done enough throughout the country. So I highlight that again, that patients should get next generation sequencing and should end up on targeted therapy where appropriate. But assuming none of those, now what?
Well, we have a lot of options. We also have cemiplimab monotherapy, cemiplimab plus chemotherapy, other regimens coming up around the bend. For me, I'm looking at PD-L1 status. I'm looking at burden of disease and comorbidities. And if patients are very fit, I'm more likely to give chemotherapy up front, especially if there's a large burden of disease. But if someone's asymptomatic, PD-L1 high lung cancer, my preference really is still monotherapy, and I like to avoid the chemotherapy toxicity. So I'm probably using pembrolizumab there alone. Nothing wrong with atezolizumab or cemiplimab, but I think there's a lot of inertia, and I didn't really see a compelling reason to change practice. Those are reasonable options. If there was a copay difference or a formulary difference, I have no problem switching, but I'm primarily pembro alone for patients without a lot of symptoms. And if there are a lot of symptoms, then I'm going to really lean towards combinations of chemotherapy with immunotherapy And my general practice is to reach for Keynote 189, again, just because I have the most experience with it. I leave room for individualization, for shared decision-making, and talking about the different options. Schedule is an important consideration as well. Pembrolizumab alone can be given every 6 weeks, which is a much more favorable regimen. For PD-L1 low and PD-L1 negative, my preference really is chemo IO. And there it's this toss-up between Keynote 189 for adenocarcinoma or Checkmate 9LA if I really think there's value in avoiding long-term durable chemotherapy. A lot of other regimens, all reasonable options. I don't think one's shaken up to the top. And I do have allowances for other options based on unique specific circumstances.
Yeah, I feel similar. I think the newer, you mentioned cemiplimab, and I'm glad you mentioned that one. I think the data from that was quite compelling, but not more compelling to move out the inertia already of Pembro. But it does absolutely justify a backbone for ongoing trials and combinations, and I feel very comfortable with a control arm of cemiplimab. And as you mentioned, if there's a copay issue or some other issue, I feel very comfortable with the idea of prescribing really any of these approved regimens. Now, you did mention a subpopulation, STK11 mutation, where you might consider CTLA4 inhibitor. So just to further flesh out any other aspect that would make you more inclined to choose CTLA4 inhibition, aside from your just mentioned issue of whether or not you'd be utilizing longer-term pemetrexed.
Well, I think CNS is a consideration as well. And if we borrow from our melanoma colleague, CTLA4 inhibition seems to boost the responses in the brain. And so I think that if someone had a lot of disease in the brain, that was an important consideration, might be a little more likely to lean towards CTLA4 there as well.
Now, for each of these time duration of treatment, are you a 2 years and stop? Are you doing any kind of assessment at that time? Is it patient to patient? What duration of therapy are you giving when effective and well tolerated?
Yeah, so I'm highly conflicted here. It's certainly debatable. When we think of duration of treatment, there's really only one randomized study that looked at this question. That was Checkmate 153, led by Dave Spiegel. And this was in the second-line setting with Nivo alone. And it was Nivo for 1 year versus Nivo until progression or intolerance. And we saw that there was not only a PFS benefit, which you might expect, but an OS benefit with continuing Nivo longer than 1 year. But that doesn't answer the question in the frontline setting, and it doesn't answer the question of 2 years versus indefinite. I tell patients up front, and I think it's important to set expectations, say we're going to continue this treatment. The tentative plan is to do this for 2 years if all goes well. If there's not major toxicity, if it keeps working, we're going to plan on this treatment for a period of about 2 years. And at 2 years, we're going to have a discussion. And I have some patients that get to 2 years and they say, I feel great. No side effects. It's working. I had stage 4 lung cancer. There's no evidence of cancer right now. We're at 2 years. Why would I stop? And it's hard for me to argue with that. When we look at the 5-year data from Keynote 24, Keynote 189, while patients that make it to 2 years do very, very well, there are late recurrences after 2 years. And I don't know if continuing therapy more than 2 years would have prevented that, if that was just manifest destiny that was going to happen regardless, or if we could have avoided that. We know that there's a response rate when you re-challenge after stopping, but the response rate is not 100%. It's more like 50-50. So I have a shared decision sort of a model in that setting. And at 2 years, we have discussion. And I'd say in the studies, we stopped at 2 years. I'm very comfortable stopping at 2 years, and then we monitor closely. But if patients feel like they're going to be very anxious, not able to sleep after stopping 2 years, feel very strongly about continuing, I also think it's reasonable to continue until intolerance or progression.
Yeah, another great setting for some kind of biomarker, whether that be like an MRD, minimal residual disease, kind of a blood-based test. I mean, I do wonder if someone has cleared by the time of 1 year and they're still having ongoing response at 2 years, are they more likely? Or, of course, 2 years is the more natural kind of a obvious time point for testing. It does feel like in the next 3 to 5 years ahead, we're really primed for a biomarker revolution with increasing technology to better assess some of the different subgroups that you've described in our discussion today.
Yeah, I think that's where we have to go. And, Jacob, I'm looking to you to lead those studies.
Well, there are a lot of smarter people than me that are working on some of this. But this has been an absolutely wonderful discussion. I really appreciate Dr. Stephen Liu joining us today for a discussion about immunotherapy for non-small cell lung cancer. And thank you for tuning in. If you haven't done so already, take a moment to download the Medscape app to listen and subscribe to this podcast series on lung cancer. This is Dr. Jacob Sands for In Discussion.
Thanks for listening to Medscape's In Discussion Lung Cancer podcast series with our host, Dr. Jacob Sands. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on lung cancer.